So, hello everyone. Today we have another clinical reasoning VMR, and today we have two guests. We have Dr. Noah Rosenberg, also. He is a PGY2 internal medicine resident at Beth Israel Deaconess Medical Center, and today he will be our case presenter. And we also have Dr. Adam Rodman, who is an internal medicine physician, educator, and also co-director of the IMED education and also the host of the podcast Bedside Rounds. And before rambling too much, I would give the mic first to Noah, who is the case presenter, and then to Adam to talk about their projects ongoing and also what they like to do outside of medicine. Yeah.
Hey everyone, it's been a while since I've been on a VMR. Nice to see new faces and old faces. I'm a second year resident at Beth Israel Deaconess. I do not really have too many projects going on. My biggest project is being a new senior/junior resident in the workroom next to Adam for the past week, which has been fun. I love to spend time outside, so I love biking and running around sort of the nearby area, and I love making pasta and pizza. So it's been like a personal project of mine.
Do you like making any food that isn't constituted of carbohydrates?
No. My one stipulation, it has to have at least 90% carbs.
Oh, so it's the opposite of a ketogenic diet. That's my chill. You eat like my, well, you also eat like me. I brought donuts to the workroom, so I don't know that I can really be an honest broker here. Hi everybody, my name's Adam. Seema wanted me to talk a little bit about what I do. So I am I'm an educator and I'm a historian. So as an educator, I'm in the field of digital education, which all of you are too. Like Rafa knows all about this, but like in the last 10, 15 years, the way that we learn, I focus on postgraduate medical education, so residency, but also in undergraduate medical education. It's fundamentally changed. And I don't think that we've truly caught up with how big of a shift this is, right? So a lot of the ways that we learn during medical school residency, and certainly for lifelong learning, have shifted into the digital space. And one of the things that I do at BI is, along with Shreya Trivedi, she's the host of Core IM, we run the IMED initiative, which is a research center. We do a bunch of studies on how people learn in this new age and best practices. And also we run a digital education track where we actually take 6 residents a year at BI who have a longitudinal track and learn how to be digital educators. And we do it for continuing medical education as well. This is what Rafa was talking about. We have an annual conference, which is coming in October 7th and 8th. The 7th one is completely virtual, and it brings people, a bunch of people that you guys know. Reza can't make it, but Robbie is going to be there actually to teach digital educational skills. And if you guys want to come, it is discounted for trainees. And obviously, if anybody has any financial hardships, just send me a message on Twitter and we can get you in. And then I'm a historian about like medical epistemology and the nature of diagnosis, which is all incredibly nerdy. But hey, I guess that's what we're doing here. I'm done.
So awesome. And there was also a question about how we sign up to this project.
I'll put the link. You could just type, it's through Harvard. So you could type in Harvard Digital Education Conference. But, you know, if I were a responsible course director, I would know it off the top of my head. But of course I don't.
Another question would be about your podcast, the Bedside Rounds, that everyone is such a big fan of it. Can you tell us more about it?
Oh, yeah. So Bedside Rounds, I started actually when I was a resident, which is crazy because I had no idea what I was doing. But Bedside Rounds is a medical history podcast. I make it with the American College of Physicians. And I don't know, I'll defer to Noah on how to describe it, but it's basically like a discussion of how modern medicine came to be, especially from an intellectual framework. So very, very nerdy. I've been working on like a history of diagnosis series for the last year and a half. The last episode I did, or last couple episodes, have Gurpreet Dhaliwal, who I know has been on VMR before. So right up, probably anybody who likes VMR is right up your alley. Getting really not only metacognitive, but metacognitive, like what historical trends and forces have shaped how we think about diagnosis itself.
So nice. So before starting with the case presentation, I would like our scribe Mukund and also the person who's doing teaching points, namely Promise, to introduce themselves.
Hey everyone, I'm Mukund, fresh second year medical student at UCSF, also freshly recovered from COVID and have rejoined the world of the living. Hello everybody, really excited for this.
Hi everyone, my name is Promise. I'm a third year medical student. Just super excited to learn from everyone and learn and solve the case.
Awesome. So I guess we're all ready to start with the case presentation. Yeah, so I would lead the mic to Noah.
Alrighty. So I'll start with our chief complaint. Given that Adam is a hospitalist, this is an in-hospital based chief concern. We use the word trigger at Beth Israel instead of rapid response. And so the page that you get, Adam, is a trigger for dyspnea. The patient was in, you're getting paged by the hemodialysis nurse. And this is a 62-year-old man.
So I imagine, well, first I actually wanted to say, Mukund, I know exactly how you feel. Dr. Rosenberg, I caught something from one of our patients, which I actually know is rhinovirus because they did a viral swab. So I am also recently back in the land of the living. So I have a lot of sympathy for you. Okay. And no, I imagine that I don't know anything else. I'm just getting this information.
Yeah, sort of the covering person, or you're just meeting them. You're called by the hemodialysis nurse for a patient, a 62-year-old man, just started hemodialysis and is now acutely short of breath.
Okay. Well, my first practice, I mean, whenever I get a rapid response or a trigger, the first thing that I always do before even looking up any additional information is I go and evaluate the patient. That would be the first thing that I would do before looking at any information going to the patient's bedside. Can you tell me what I would see when I get to the bedside?
Of course. So this is a 62-year-old man. They just is attached to, dialysis right now, has a tunneled line in the left side. And when you examine the patient, they appear in respiratory distress. So they're tachypnic. You don't know the exact rate, but they're breathing pretty fast. Yeah. They're sitting in the mid to high 80s. And when you examine them, you don't note any significant peripheral edema. It's tough to assess. They are a patient with ESRD on dialysis, so they do have some chronic edema, but no known whether it's acute or not. And you listen to their lung sounds. You do hear lung sounds in all fields. Okay. It's tough to say, whether there are some crackles at the bases or not, and whether you hear full breath sounds there. They're taking fairly short breaths, but you can definitely hear them. They don't have any new murmurs from what you can tell, but you do hear a hollow systolic murmur that's been noted in the past. Okay. And then they don't have a very significant elevated JVP from what you can tell.
Yeah, and so this is a very unique type of diagnostic medicine that's different from, for example, I do actually work in the clinic also, Noah. I have my clinic tomorrow. But
I only just see you in the hospital.
I know. But this is different because when you're reviewing somebody in whom a trigger or rapid response has been called, the first thing that you do, like metacognitively, is triage. And you want to triage first, is this patient in rapid risk of decompensating now, to the point that you need to start thinking about, is the ICU appropriate? Is this a patient who needs immediate management at this moment in a way that I can keep them from decompensating further? And then after that, like what actually is going on in a way that I can manage? So the first thing that I would say, you say he's tachypnic. Is he using his accessory muscles of respiration?
Yeah.
He is. So he looks like he's tiring out?
Tough to say whether he's truly tiring out, but he's certainly using his abdomen to breathe.
Okay. Is he able to speak in complete sentences?
Tough to say, but able to speak, but not full sentences.
Okay, not full sentences. On his exam, are his extremities warm?
Yes.
Okay, so basically looking for signs of respiratory collapse, which unfortunately Noah is describing a patient who is showing signs of respiratory collapse. In terms of cardiovascular collapse, he has warm extremities. That I think everybody here knows there's many different types of shock and you can be thrown off, right? A distributive shock can initially be warm, but at least initially it's a reassuring sign. And I didn't ask you, do we have his vital signs during dialysis?
Yes, we can. Let me just bring them up quickly. Briefly, afebrile. Pressures off the pressures were stable. Their baseline hypertensive right now, they just started dialysis, was in the 140s over 70s. In terms of the respiratory rate, again, tough to assess, certainly above 25. And then setting again to mid to high 80s, had just been placed on nasal cannula when you arrived.
Mid to high 80s on room air previously?
Yep, and then was on 2 liters nasal cannula when you arrived.
And okay, so and then on 2 liters nasal cannula, and how are his saturations now?
So it increased a little bit, maybe high 80s, but nothing significant.
So they're not correcting with oxygen. And were I to turn the oxygen up, would he correct with oxygen? Like as I'm in the room evaluating him?
Maybe slightly, but tough to say if they'd fully correct. I don't think you'd fully correct them.
Okay. Let's see. Anything else that I want to ask on exam? The nurse, I imagine, is there at the bedside, right?
Yes.
So while I'm evaluating the patient, even before I've looked in the chart, I would ask, I'd ask the nurse, what happened? What do you know about this patient? What's going on?
Yeah. So this is maybe time for a little bit of background about the patient. So, you're reading through you're able to take a look through your census, sign out at the same time you're listening to this nurse give you information. So this is the patient's first time in dialysis here. They were just transferred from an outside hospital. This nurse is unclear why, but it seems to be some sort of valvular workup.
A valvular workup?
Yep. That was the initial reason they were transferred, some sort of valvular workup. And you go back in the chart and you realize they were transferred for a mitral valve repair.
Okay.
And this is the first time they've had dialysis here, but they have had episodes of this shortness of breath in the past. They've been diuresed at the outside hospital during these episodes, and then placed on BiPAP intermittently during these episodes. And they've always resolved after a few minutes to maybe 10 to 20 minutes.
And what is he's end-stage renal disease on chronically on hemodialysis?
Yes. Has a tunneled line in the left, and it has a fistula that is being matured on the right.
Okay. There's a fistula. So this is relatively new dialysis. I can tell just by looking at him based on the fact that he has a tunneled line and a fistula. On examination of the fistula, is everything normal? There's a good palpable thrill. And in feeling peripheral pulses, for example, the radial artery on that side, it's normal strength. No asymmetry between the two sides.
I wasn't there, but the report says yes.
Okay. And during dialysis, what were they doing? Were they taking off ultrafiltrate?
So they were taking off ultrafiltrate, but it was about 5 to 10 minutes into dialysis, so they had actually just started the session.
Okay, fascinating. So at this point, I haven't even really looked in the chart. I've just talked to the nurse. So can I kind of summarize what I know at this point? So 62-year-old man, end-stage renal disease on chronic, he's on chronic dialysis therapy, though started relatively recently with severe, I assume he has mitral regurgitation, unclear causes, but severe MR, who is transferred here for surgical repair, who develops what sounds like recurrent severe, not just dyspnea, but also hypoxia during the initiation of HD, not even that much into it, right? And that previously is corrected on BiPAP. Now very, very tachypnic, in respiratory distress. And what I find very interestingly is that his hypoxia is not really correcting with oxygen. Is all of that accurate?
Yep, I totally accurate. I will say The episodes have resolved with supplemental oxygen or positive pressure in the past, and he has always been diuresed during these episodes, and sometimes they haven't occurred during HD. It's been very unclear whether they've happened at the beginning, an hour in, or even before HD.
Okay, and then some additional exam questions. You said that there was no elevation of his JVP. Could you not see it, or is there a JVP elevation and it's not particularly elevated?
Tough to say. Slight elevation via ultrasound, but you don't see it on physical exam. So
Oh,
you
so
can't.
we have an ultrasound that we can evaluate with?
Well, it was just my bedside focus.
Did you get a good look at his IVC?
I did not, unfortunately.
Okay. Any lower extremity edema?
Yes, but it's been noted as a chronic issue.
Okay. It's been noted as a chronic issue. And then in terms of his lung exam, you said it's clear in all fields. Were there any crackles or any other thing that could suggest volume overload on his exam?
So clear, but sounded tight. And then crackles in the lower bases.
And then crackles in the lower bases. Okay.
Well, bases.
This is great. So again, I'm standing here at the patient. At this point, just a few minutes have gone by, and I'll tell you where my mind is already going. So when you look at the acute workup of dyspnea, like acute, there's a couple ways to look at this. When I was a med student, I was taught the dyspnea pyramid. Noah, do you know the dyspnea pyramid? Does everybody know the dyspnea pyramid? I would love to show it to you. This is, it's from UCSF originally, and then Jeff Weiss brought it to Tulane. I used to work in Botswana. That was my first job as an attending, was in Botswana. And I remember that my jaw just hit the floor when one of my interns, who's Botswana, brought up the dyspnea pyramid during a report just like this. The basic idea of the dyspnea pyramid is that there's 4 overall levels of things that can cause acute onset of dyspnea. At the bottom, there is cardiac. Right above that, there's pulmonary on the bottom. What am I talking about? Then above that's cardiac. Above that is, this shows you how much I remember, it's acid base, right? And then at the very top is hematologic causes of dyspnea. And it's basically, it's both a systemic way to think about it in the moment, and then also a way to guide your next diagnostic steps. So when I'm hearing this story, that's where my mind immediately goes, is how do I think about this in terms of the dyspnea pyramid? And there's a couple things on here that point me in different directions. I mean, as a very, very nerdy internist, the fact that there is hypoxia that's not completely correcting with oxygen clearly has me pushing in the area of a shunt, right? That there's a shunt somewhere in this man. The shunt workup can be quite complicated, but that's like one of the first things I'm thinking of. But I don't want to anchor there, and I want to have a very kind of systematic way of thinking about this. There's other things. This history of BiPAP, of positive pressure, making dyspnea better, really suggests pulmonary edema. Now, Noah pointed out that, I don't really hear crackles on exam. I tried ultrasounding, but it's not that great. Noah, do you have a sense on how predictive the presence or absence of crackles are for volume overload?
They're unfortunately terrible.
Yeah, they're terrible. I would never allow, like in made-up case presentations, sure, you can use crackles, but in real patients, I would never let the absence or lack of crackles drive me one way or another. So I'm not going to lie, pulmonary edema is still very high on my differential. At this point, I haven't even reviewed this guy's meds, right? So I don't know, is he anticoagulated? Is he not anticoagulated? There's actually quite a bit of controversy about the role of anticoagulation in end-stage renal disease, even though the practice pattern at our local institution is to anticoagulate everybody. I'm sure everybody has seen different things at their institution, but pulmonary embolism. Now, it's unlikely that if this is something that's happened previously during hemodialysis, that this could be a PE, but we're hearing, he has hypoxia that's not acute onset, hypoxia that's not completely recovering. Could this be a pulmonary embolism? Absolutely. It's definitely on the differential. Could this be another cardiac cause? Could he have had an MI while we're just sitting here? Again, it's less likely, especially with his history, but could he have had some sort of anginal equivalent? He gets stressed, his blood pressure has been high. That seems less likely, but it's certainly a possibility. So I'm still considering cardiac causes on this. In terms of acid-base things, this is getting a little wackier because hemodialysis should not in and of itself cause us, unless someone has really, really messed up, should not cause a severe acid-base disturbance. Could there be something like methemoglobinemia? I don't know his history. It's unlikely. It's not what I'm thinking right now, but it's certainly something that I'm going to keep in the back of my mind. Dr. Rosenberg, is that a pretty good differential there?
That was brilliant.
Yeah, so this is why I love that it's an acute case. And the reason that the dyspnea pyramid is so important and why the diagnostic thinking in medical emergencies, this is why I kind of love, sometimes I'm like, I should have been an emergency room doctor, is because my differential is going, oh, the CI bucket fell into the dialysis. Exactly, that's what, so they would have had to mess up the dialysate in order for that to be an issue here. And I hope that's not the case, but it's a possibility. So do you want me to tell you what labs I would immediately get while reviewing his chart? In studies, I'm going to order in the dialysis suite, I'm going to order them to get a VBG. I'm going to order them to get a stat. These are all stat, an X, a CBC, BMP, a troponin, and then I'm going to get an, you'll know me, Noah, I actually generally hate portable x-rays. If you are in a facility that's capable of doing a PA in lateral, you should always, but this is a case where I want it fast. I want to see it when it's done. So I'm going to get a stat portable AP x-ray.
Alrighty. So we'll start with the gas, which comes back first. The blood gas shows a venous pH of 7.33, a PCO2 of 44.
44, okay.
And then a total CO2 of 22. The lactate was 0.6. I don't remember the trope off the top of my head, but it was low enough to where you feel comfortable. In terms of an initial CBC, your initial CBC shows a white blood cell count of 10.7, hemoglobin of 7.7, platelets of 211. From pre-admission, those are about baseline, if not slightly above. And forgot we asked a BMP. Again, this is sort of in right before dialysis had happened, but the creatinine is 8.8, BUN is 55. I'll start in order for the rest of them. So a sodium of 135, K of 4.3, chloride of 94, a bicarb of 20, and then at that gap is 21 with corrected his with the albumin is about 22, 23.
Wait, sorry, what was the CO2 on the BMP?
20.
Oh, so okay, so the CO2 is 20 and the PCO2 on the VBG is 44. Do we have any older baseline VBGs, or I imagine not?
Oh, this is the first time they've been here, unfortunately.
Yeah, of course. Okay, so, and then the x-ray, what does the x-ray show?
Oh, yep, so the x-ray shows mild interstitial pattern, could be consistent with pulmonary edema. And then no significant pleural effusions, no focal opacities. That would be concerning from the radiology read for a pneumonia or a specific lobar pneumonia in this setting.
Okay, and
No,
the EKG
no
I imagine
pneumothorax.
shows no acute MI, no evidence of
Yep,
ischemia.
exactly.
Okay, yeah, I should have mentioned pneumothorax on the differential, though the physical. Oh, this is very, very interesting. So this is why I love, is it, oh, that's a great question.
That is a good
Sorry,
question. I don't know off the top of my head.
Is you said the potassium is 1.3?
No, 4.3.
That's what I thought. I heard it 4.3. That's why it worked. Okay. I was like, well, how did
you're
I
all
miss
good.
that? I need to pay better attention. Okay, so this is why I love the dyspnea pyramid as an advanced organizer for acute dyspnea, because with these studies, we can start to X off a lot of things. So the bottom of the dyspnea pyramid has a lot of pulmonary causes. For example, pneumonia and pneumothorax are both things on my differential that I feel reasonably confident about crossing out right now. In terms of cardiac causes, I think unstable angina, ACS, much less likely with a negative troponin. Not totally negative. I mean, obviously troponin takes a while to rise, but this is reassuring against that. Similar with an arrhythmia causing dyspnea, though it wouldn't really cause hypoxia. So I think we can say that is much less likely. What about cardiac tamponade? Actually, no. Did you put the probe on his chest at all?
Yep, no significant effusion. I'm not the best at looking for invagination of the RV, but it did not see any.
But there's no effusion. So yeah. I think tamponade is much less likely. Heart failure? Well, interestingly, there's mild pulmonary edema. That's not at all unusual in dialysis patients. I'm going to keep it on the differential, but this is, again, not as, this isn't what I would expect for flash pulmonary edema. And if he had already flashed, he should be improving right now. And the guy's in front of me and doing no better. So what was his hemoglobin again? It's 7.7. He is anemic, but it's about where it's been, right? So no reason to think that anemia is driving all of this. We do not have a, we don't have, like for methemoglobinemia, we don't have all those other hemoglobin tests. Those are pretty low on my differential right now. So big things that I'm still considering on my differential. So first of all, a pulmonary embolism is always going to be on your differential. Soon, because I'm going to order some more tests, I'm going to review meds and stuff in the chart. But a P is definitely on my differential. I'm not going to lie. I'm becoming increasingly suspicious that something acid base and potentially a shunt is going on as well. Honestly, let me take a look at this. So his pH is 7.33. This is a VBG. It's not an ABG. That is a relatively normal pH. His PCO2 is 44. PCO2 on that's actually no, that's normal on a VBG, isn't it? That's within the range of normal.
Yeah, I will note that the patient is breathing very fast.
Okay. So that's the key here. The patient is hyperventilating and the PCO2 is only 44. Got it. Somebody spilled cyanide in his dialysis fluid. That's a good one. Okay. What do you want me to do? You want me to do another summary statement before I tell you what my next thoughts are? Or
I'm happy to do that. I can also let you know what the team did at the time here to see if that helps. Whatever you prefer.
Whatever you want.
Yeah, so maybe I think it'll be a little context. So the team saw the mitral regurg history, the mild pulmonary edema, and did give a significant dose of IV Lasix, and actually did place them, because it was not correcting, place the patient on BiPAP and move them to the CCU.
And that's not unreasonable. I that would have been my next step while waiting up for things, is to add some positive pressure in. And I don't know how much urine this guy makes. I guess they didn't know either, right?
Yeah, a little bit, but nothing much. And the patient actually, within about 10 minutes of this episode, ended up getting better. I will say, once this started to happen, obviously dialysis was shut off and the patient was disconnected. Yeah. And so this actually ends up happening 4 to 5 more times while this patient is trying to get dialysis in the CCU. And I think this is where I'll stop and maybe give some more laboratory data, because I think this will be a little bit helpful here.
Yeah, and this is not consistent with mitral. Like, did they think that this was flash pulmonary edema because of his wide open mitral valve?
Yeah, initially, so the patient initially came to the cardiac service here, and given the history, the TTE at the outside hospital showed moderate to severe. The TEE showed around moderate mitral regurg with a couple flail leaflets, and so the evaluation was for surgical repair here. And so they initially treated this patient for flash pulmonary edema, but the CCU team, the cardiac ICU team, got a little more suspicious that this might not have been the case. And so they added on a few more labs. And so I'll give you guys some of the repeat labs that they ordered when any patient comes to the ICU. They ordered another CBC, but this time with a differential. And so the actual CBC stays about the same, but the differential shows a neutrophil count of 60%, lymphocytes of 4%, monocytes of 6%, eosinophils of 28%.
So just to be clear, that's about 3,000 EOs, right?
3.9 thousand.
Yeah, 4,000 EOs. Jeez.
Yeah. The rest of the labs are about the same.
Well, that threw a curveball that I didn't expect.
I did play baseball.
Okay. So the patient is yeah, it's whoever said that, Dr. Silva, is completely right. This is a marked absolute eosinophilia. The patients in the ICU, do we want to go over? I assume they're much more stable now. Do we want to go over the rest of their medical history? Since
let's
presumably that's what I would do on admission to an ICU.
Yeah. So the background is that this is a 62-year-old man, unclear but presumed diabetes and hypertension induced ESRD, has a history of heart failure, preserved ejection fraction around 60% with this mitral regurgitation, has a history of COPD, and then epilepsy diagnosed in February of that year, and was started on Keppra.
By that year, you mean this year?
Like this year. Yeah, like okay. six months before presentation. In terms of further background, you speak to her and she'd had trouble breathing for the past 1 to 2 months. It had always been worse at dialysis and helps with an inhaler. Has had a few admissions to a nearby hospital for this, but has always been discharged within a few days. In terms of the other past medical history, beyond that, she also has this unclear peripheral neuropathy, but had not been bothering her recently. No, in terms of her social history, sorry, I'm going fast, so let me know if I need to slow down.
No, I'm good.
He lives with her daughter. No clear environmental exposures that you know of. They don't have any pets. They haven't traveled outside the country recently. They don't have any other clear triggers at home, and no history of atopic illnesses in the family or other cardiopulmonary issues. The patient is from Haiti, but moved here very young. And then in terms of home medications, it is a long list, but I will happily go through it. I'll give you the highlights.
Yeah, give me the highlights.
So the patient is on an inhaler, budesonide formoterol, is on valproate and levetiracetam, is on hydralazine, is on loratadine, is on some hypertension medication, specifically including the hydralazine, is also on amlodipine and is also on metoprolol, and then is also on a statin, simvastatin. There are a few other medications, but I don't think they're needed to go through here.
Okay. Noah, I'm obviously going to review previous records in this.
Yes.
Has there been eosinophilia noted previously in her history?
There is. It all started it was all noted first at the outside hospital when the patient first saw a pulmonologist for this issue in February of that year. So 6 months prior. We don't have any other records since that follow-up. They had an initial, follow-up, was diagnosed with COPD. And this eosinophilia was something that was being trended, but there was some absolute eosinophilia.
And how high was it back then?
About the same, in terms of percentages, somewhere between the 20 and 28%, absolute, somewhere between 2 and 4,000.
Okay. Have there been any CT imaging of her chest?
There's none done prior.
Okay.
But we did have CTs during the admission.
Do you want to talk about that right now or not yet?
Happily.
Well, can I ask you another question about history? Tell me about the renal failure. Like what do we know about her renal failure? What had been worked up? It's like what's the etiology?
Yeah. So the etiology is thought to be diabetes and hypertension. The patient did not get a renal biopsy, from my understanding. And was, as I talked about, sort of had this left subclavian tunneled line, and then had a right brachiocephalic fistula that was being matured. The patient had been on dialysis for a few months before this started. So it was about a year of dialysis before this patient developed these symptoms. That's really all we know about their dialysis. I'd say, it was a pretty convincing story, according to the dialysis team, that this was hypertension and diabetes induced.
And we don't necessarily have a good tempo of worsening CKD. No, we don't know.
It seems to be fairly chronic, progressive. There wasn't anything clearly acute. It didn't appear to be rapidly progressive. And the patient did have proteinuria noted before the progression of CKD.
Okay. Can I do another summary statement and tell you where my thoughts are? Because this is great. Okay. So yeah, there's some great comments. There's some great comments in the chat. So the addition, well, I'll give you my summary statement and I'll tell you how this affects my thoughts. So we now have a patient who is developing acute onset respiratory distress with mild interstitial pulmonary edema with, again, a suspicious VBG, like an inappropriately high PCO2, only during dialysis that intermittently, we don't truly know if it responds to Lasix and BiPAP, it may just get better on its own, but that has been happening regularly for the last 6 months in a patient who also has an absolute eosinophilia. Hey, there's other things that we should think also. She has a new diagnosis of a seizure disorder and has recently been started on a new drug, Keppra. She also has a history of lung disease as well, and a history of heart failure with preserved ejection fraction. No other new medications other than the Keppra, Noah, is that right?
None.
Yeah. So this is interesting because eosinophilia, as you can see from the chat, gets everybody excited. Loeffler syndrome is getting thrown around a lot. Loeffler syndrome is when you have there's a bunch of different nematodes that can do it, but when they you get respiratory symptoms when they migrate across the lung, and they can cause like patchy opacities that switch directions. It's very cool. The problem is that, this is why I love diagnosis, right? We want to put everything together. The eosinophilia certainly could be related to all of this, but we have to keep an open mind that eosinophilia, especially in certain parts of the world, are not necessarily uncommon. If you look at the guidelines, usually just testing for strongy is the first thing they recommend in the United States for an unexpectedly elevated eosinophils with the absence of other symptoms. Now, this is not clearly the absence of other symptoms, but we just don't know how related they are. Certainly, she is from Haiti. I don't know how often she goes back, what other exposures she could come from. It sounds like she's lived in the United States for a very long time. So something like incidental strongy is possible, but it certainly could be overlapped. When you look at pulmonary syndromes that also have eosinophilia, I think this is probably where everybody's mind. Oh, that's great. You guys are going to mention a lot of nematodes. So I did used to work in Southern Africa, but it's very, very dry. So I actually am not very good at tropical diseases, but these are great, what everybody's suggesting. But yeah, so looking at an overlap now of eosinophilia and acute onset respiratory diseases is a little trickier. There's a bunch, right? So obviously there's eosinophilic pneumonia, there's ABPA, there's a DRESS syndrome that can have, there's a lot, right? There's a lot of overlapping. There's EGPA, where there's an overlap between eosinophilia and pulmonary symptoms. What's really getting me though, Noah, is this strong association with dialysis and this acute onset shortness of breath, right? That's what I'm trying to put together. And I want to make sure, I don't want the eosinophils to necessarily move me in the wrong direction before going crazy for figuring out that, because it's such a strong association. The other thing, and this is me going very, very crazy. There's case reports that are much, much older, but people can have allergic reactions to things that are within the dialysis circuit. And you see this, yeah. So that's certainly a possibility. This is well beyond my own expertise. Noah, how does that sound? Should I tell you what tests I'd want to order next?
Yeah, that was amazing. Yeah, go for it.
That was amazing. I don't know that it's amazing.
You're certainly the best MD in the FAR 7 workroom, I'll say that.
Okay. So we've done our exam when the patient was in extremis. One of the next things that I'm actually going to do is a full physical exam, of course, but in particular, looking for any lymphadenopathy, looking for any skin or joint changes, and asking the patient about any of that. Looking for any signs, effectively, of a rheumatologic or proliferative disease, including a breast exam.
Gotcha. So there are some chronic, joint changes. This patient actually ends up telling you they do have a history of osteoarthritis, but there are no clear rashes or joint changes that would make you concerned about a rheumatologic condition. Okay. There are no masses that you palpate on abdominal or breast exam. There's no lymphadenopathy, cervical, supraclavicular, or otherwise that you can, or inguinal that you can clearly feel. Anything else from the exam? And
now that the patient is no longer at extremis, I certainly would want to redo a pulmonary exam, a good pulmonary exam. And in particular, just to be clear what I'm listening for, because, I poo-pooed crackles. Well, this time I am listening for crackles, but very, very fine crackles, anything at the bases that might suggest a fibrotic process.
So you maybe hear some crackles that are similar to before. They sound a little wet, but you don't hear any other breath sounds that are abnormal. You hear clear lungs, good inspiratory effort, and it doesn't seem as tight as before. Okay. And again, a JVP evaluation, euvolemic? Relatively euvolemic, maybe slightly overloaded. Okay, maybe slightly overloaded. Okay. I will tell you what my next diagnostic steps would be. I imagine that the team did all of these things. I would want a formal. I'll go on the record as saying that I am not a big believer in ABGs. I think they are drastically overused. They make patients very, very uncomfortable.
However, one of the times that you want to use an ABG, well, there's really two. You want to look for a shunt, or you want to look for one of these other hemoglobinopathies. So I would actually do a formal ABG. I'm also going to get a CT chest with contrast. You know what? She's not on a blood thinner, right?
Nope, no.
Yeah, so the challenge here, like, is showering a clot on the differential? It probably is. So I would probably go ahead and get a CT with angiography. That's really low, and something like CTEPH, the chronic thrombotic embolic. Oh my God, what does CTEPH stand for? This is why I hate acronyms. Chronic thromboembolic pulmonary hypertension. Yeah, you like that? And it's not something that I'm really thinking about now, but the problem, oh my God, this is putting me on so many rants. PEs in the hospital are really, really scary because they're not uncommon and we don't have a good way of risk stratifying them. So you have to have a very like low index of suspicion of testing for a PE. So I would go ahead and get a CTA to make sure that there's not a PE. Gotcha. And that would really be, and I'm going to get a formal echocardiogram as well, but my first two tests would be the ABG and a CTA.
Gotcha. I have a CT with IV contrast. I unfortunately don't have a CTA. I actually don't have an ABG. I don't have an ABG for you.
No one did an ABG?
Okay. No one did an ABG. I'll tell you who to take it up with after. In terms of the CT chest, there was a small consolidation in the left lower lobe, compatible with a possible aspiration in the right setting, a very small left pleural effusion, mild interstitial pulmonary edema, no evidence of adenopathy in the chest, mild upper lobe predominant, centrilobular emphysema, but that's really about it. They do not see any interstitial fibrosis or other signs of fibrosis or clear ground glass opacities.
Oh, okay. So this is fascinating. So this does, like, the differential starts to change immediately because of the lack of any inflammatory changes. I mean, I don't want to say this is a benign CT. Obviously, this patient has evidence of their COPD and maybe some mild volume overload. You know, they're oliguric ESRD and CHF. But this is shifting my thoughts, right? A lot of the things that are in our differential for things that cause eosinophilia and like Loeffler syndrome, for example, would cause opacities that you would see on the CT scan. I'm not going to lie, this actually pushes my suspicion that we are dealing with something allergic rather than a primary pulmonary process, but very, very interesting. Okay. And we don't have an ABG, and I imagine that because this is the BI, I imagine they got a formal echocardiogram. I don't know that it's essential. I'm just curious.
They didn't.
It's not necessary.
I'm just surprised they didn't. I'm scrolling through the reports right now, and I realized they didn't.
Okay, so I'm going to do another summary statement because this is a great case, because what we have here is a patient who has transient hypoxic reaction. So I'll start over. This is a patient who's on oliguric ESRD on chronic hemodialysis, heart failure with preserved ejection fraction, originally from Haiti, with newly diagnosed epilepsy. And I didn't even ask you, Noah, how much we know about her epilepsy. Was her head imaging done?
That much, unfortunately.
We don't know.
We don't have any yet, unfortunately.
Newly diagnosed epilepsy on levetiracetam, that's Keppra, an anti-epileptic, which is a new drug, who is presenting with recurrent severe hypoxemia that doesn't really correct with oxygen, of limited duration, maybe correcting with Lasix and BiPAP, maybe not. Also found to have severe eosinophilia. Labs notable for inappropriately hypercarbic, other end than really a severe or like a marked severe eosinophilia. And then pertinent negative findings, a relatively benign physical exam with clear lungs, right? With no evidence of what am I trying to say, of any opacifications in the lungs that might otherwise explain her respiratory symptoms. Mm-hmm. Yeah, Sammy really wants a tryptase. Did you guys get a tryptase?
There is a tryptase.
What is it?
It's the tryptase. There were multiple tryptases actually obtained. The initial tryptase is 37.7, which is elevated in our reference range, less than 11 micrograms per liter. I'll complete sort of the eosinophilia workup that we ordered,
Yeah.
or that the
I
that the
mean,
team ordered.
just so I'm thinking out loud, what everybody knows
Yeah.
at this point, like I'm going down the allergy route, right? Clearly, I didn't want to be thrown off by the eosinophils, but we're at the point where I'm like, look, I've tried to exonerate the common things. I think it's time to chase down the eosinophils as the possible explanation. And again, the fact that it's associated with hemodialysis makes me think that the trigger is somewhere in the hemodialysis circuit. Go ahead, Noah.
No problem. And I'll throw Corey a bone here. One of my favorite episodes is an episode of eosinophilia with GI disorders they did, where instead of using the NAACP, they actually use the schema worms, wheezes, and weird diseases, and that's sort of what I use as my approach to eosinophilia. So worms being parasites, wheezes being atopic disorders, and weird diseases being all the primary hematologic manifestations. So that's what we use to guide our workup here.
Do you want to do? Yeah, I think worm, wheezes, and weird diseases is pretty good here. Weird diseases, we're not seeing a lot of evidence for. Wheezes, we're not seeing a lot of evidence for. I think the first W is where the workup's going to be. But tell me about the eosinophilic workup.
Amazing. So we got an IgE that was 2,281. Our reference range is less than 114 is normal. There was a negative aspergillus galactomannan, a negative beta D glucan, negative ANCA, negative strongyloides, negative histoplasma, negative respiratory panel that was obtained, negative stool ONP, and then at this point, allergy had been involved and recommended sending a respiratory allergen panel that I have absolutely no clue how to interpret, but there were some things that this patient was allergic to, like dermatophagoides farinae, which I'm still not 100% sure exactly where that fits in with my understanding of this case.
I was going to say, can you tell me what that is? It sounds like it lives on the skin based on the name.
Exactly. It's some skin related thing. That's all I know. That's really the initial workup that was sent. The parasitic workup, the fasciola, all of the other echinococcal diseases were not initially sent up. I'm happy to stop there or talk about what we did next as a diagnostic step.
So what you did next is this going to be some allergy test that I don't know, or are you?
No.
Then I have a feeling I know what you guys did next. Well, maybe I don't. This is such a fascinating case. I mean, it makes you look back at the other things that have happened recently and try to put it together as a unifying diagnosis. Like this new history of a seizure disorder without anything else really has me thinking, of course, because there are parasites that can cause seizure foci, which makes me wonder if she ever had a head MRI or evaluation of her head. I'm pretty sure that's not what you're going to tell me that you did. The other thing, when you're looking for nematodes of any sort, the liver is a common place for them. The type of parasites that are bloodborne are unlike parasite smear is unlikely to provide anything here. So we're definitely getting near the end of my knowledge in doing this. So I'd love to know what you guys did for your next step in workup, unless anybody else has an idea.
Yeah, the chat has been amazing.
The other thing, a BAL could be another thing that you would do. Challenging because she's not. BAL is probably going to be where there's some yield there as well.
So I'll mention the other services that were involved because they really helped out with this case. So allergy, pulmonary, hematology, and ENT, because at one of these episodes, inspiratory stridor and expiratory stridor were potentially reported. And so the ENT actually did a bedside scope during one of these episodes.
During the episode. Okay. And what did they see?
Unfortunately, nothing in particular apart from some slight angioedema. And then maybe some edema of the vocal cords, but beyond that, nothing specific.
Yeah. Okay. I'm curious to know. Tell me.
Yeah. And so we spoke. So we spoke with the dialysis team, and our approach was first we thought that there was something going on with dialysis. Clearly, the timing is fitting too well, and we don't have any clear etiologies. So first they switched the diastolate to no avail. Then they switched the tubing that connected to the the tunneled line. That did nothing. And then it was also noted that when this patient's line was being flushed or used for something else, this reaction happened once as well.
That's on the line. Oh my God.
And so the next time actually, this was the day we assumed care. The patient was transferred from the CCU to the MICU this day, but we ran HD through the patient's matured fistula for the first time. And that episode, they did not have any reaction. And so then after that, the patient was actually started on a course of prednisone, and the fistula was used, this line was removed, and the patient had, I think, maybe one small episode at some point, but has not had significant episodes since, was discharged a few weeks later.
With the line still in?
No, the line was removed.
Oh,
don't
thank
worry. But yeah, so we took our time. We really were worried about, giving almost a diagnosis of exclusion in this case, but felt that the workup had been pretty thorough and the timing was just too consistent. And so the patient ended up with a label diagnosis, because I know it's tough to make this a firm diagnosis, but a label diagnosis of dialysis-induced bronchospastic versus, anaphylactic-like reaction in the setting of chronic hypereosinophilia from dialysis.
That was an amazing case.
Yeah, it was pretty cool to be a part of.
I've never seen this before, by the way. I've never seen a case of this.
I was on my MICU long call, and I heard about the patient in the evening, and it was a little bit of a quiet night, so I started to do some digging that night and just looked up case report after case report of what was going on.
And what do they think it is? What do they generally think it is that causes it?
It's fascinating. So the short answer is not really sure. Some people mention diacylate, some people mention the tubing itself, some people mention the line. It actually depends if people have different reactions, but there is association in chronic HD with eosinophilia. And there's also, in up to 10% of patients who get dialysis, there is this potential complement activation process that occurs that causes a bronchospastic process. And
was
so
complement
even
low in this patient? I assume you guys checked complement.
It was actually normal.
Okay.
But I don't know exactly at which point the patient's complement was measured. It wasn't sort of at the exact moments.
I mean, I imagine. Well, did you culture the line? Did you look for anything?
The line was cultured. I don't think anything grew from it. But yeah, it's this condition that's pretty rare case. Like, there's really just a couple case series of this that I've seen. But it is a known phenomenon that some patients who have chronic hypereosinophilia get this bronchospastic reaction in the setting of dialysis. And when they switch, the diacylate, the tubing, they move to a fistula, they get steroid treatment, they end up doing better and not having these reactions.
Okay. That was amazing. I have nothing more to say.
Wow, absolutely amazing case. I can already see that the whole chat is already on fire. There was also one question regarding whether you have also checked for some bone marrow disorders.
Yes. So hematology was consulted. A peripheral smear was done. A bone marrow smear was not obtained, just because from their evidence that there wasn't enough to indicate a bone marrow biopsy from their perspective. I will say there was one, Valeria, you mentioned the elevated beta-D-glucan. The second beta-D-glucan that was measured was actually elevated. And so it was actually thought to be in the setting of HD. But really there was no other further workup from the hematologic perspective that was pursued at this time. The patient declined a biopsy.
Oh, amazing. So first of all, thank you so much, Noah and Adam, for coming. It was such an amazing experience listening to you both guys, like in a live podcast. So thank you so much. I learned a lot. And before now I would hand over to Promise for the teaching points. So yeah, and also thank you so much for Mukund for this amazing scribing.
Hi everyone. So we just walked through a very complicated and also fascinating case. So I'm going to do my best to recap everything and pick out the most important points of this case. So we started with a 62-year-old male, triggered a rapid response by a hemodialysis nurse for acute dyspnea. And so Adam talked about the acute dyspnea pyramid, which I think was very educational for us all. And we would definitely start from the base, thinking about a pulmonary cause. Most common inpatient dyspnea cause would be a PE, and then we would think about acute respiratory distress syndrome, pneumothorax, pneumonia, asthma, COPD, or effusion, and then we would move up to a cardiac cause, which we would think about MI or ACS, arrhythmias, heart failure, or tamponade, and then we also have accident-based causes as well as heme causes. So with this patient, I think the first pivot point I've identified would be Adam's approach of evaluating the patients, looking for signs and symptoms of respiratory collapse, like a cardiovascular collapse, fluid overload. So he's really tackling the two broadest bases from the bottom. And then he asked a lot of questions to kind of get more information to either root out something or kind of like root into, and like how he would move his differential based on the information that he's getting. And then I think the second pivot point of the case would be once the patient was transferred to the ICU, he with a repeat CBC differential, we got the curveball of a eosinophilia, and it's a markedly elevated eosinophilia. So that entirely changed our differential, and everyone was talking about the worms, the wheezes, the weird diseases. And so I think it's also really great that Adam reminded us how important it is to go back to the previous records to look for whether or not there's a trend of eosinophilia. So is this like a first time, or has there been like a chronic eosinophilia process? And also getting more information on the renal failure, that we realized that there's like a strong association between the patient's dialysis and eosinophilia. And so we talked, and then Adam kind of asked a lot of questions, kind of looking into the autoimmune signs and symptoms, thinking about whether this may be a rheumatologic condition and like malignancy process. And we also, I think another thing I've learned from this case would be when you're not really sure where to hone into in your differential, go back and redo an exam or redo a test. So we redid like a pulmonary exam for fine crackles and to kind of see if there's any suggestive of fibrotic process. We ordered additional tests to look for inflammation, and we found out there are no inflammation changes. So that also changes our differential. And I think I've really enjoyed how Adam would take his time to pause and really summarize all the information he's gotten when there is so much information available. And his summary statements constantly evolve. And I think it's so great that we all got to experience how that has been evolving. So I think the third pivot point would really be doing the tryptase test and realizing that the IgE of this patient, both the tryptase and the IgE, are very elevated. And so that gave us like a very specific clue into the differential. And with the IgE, that really pointed us into thinking about allergic causes and or get to the diagnosis. Thank you everyone for an incredibly educational case, and it was so fun to work with, see everyone participating in the chat.
Thank you, Promise, for these superb teaching points, and I guess concluding for this amazing discussion and this amazing case presentation. I would say this whole episode was full of worms, wheezes, and weird diseases. Our new favorite pearl. Yeah. So thank you so much, Noah and Adam. It was such a pleasure. So bye.
Thank you guys so much for having us. Well, I had a good time. I don't know if Noah
Yeah,
did,
no,
but
I had a great time. Thank you so much.
Bye.
Bye. See you all.